last block, or our last class for trauma, unless I forgot one. I feel like missing some, but it's all right. You guys will still be all right, I promise. All right, we'll do some quick check on learning here. So according to nexus criteria, which of the following findings require imaging C-spine in a trauma patient? I know we just covered it yesterday, and you guys have 2 tests before mine, but
Charlie?
see if we can get it. Yeah, it's going to be C, right? So, if they have any distracting injuries, no painful distracting injuries, then we can clear them, but that one's clearly going to be a painful distracting injury. Good. All right, let's try another one. What is this one? All right, 42-year-old male firefighter is brought in by EMS after sustaining 30% total body surface area partial thickness burns to his abdomen and bilateral legs. No evidence of trauma. Initial vital signs: blood pressure 1 to 270, heart rate 124, respiration 28, respiratory 35% on 100% oxygen for non-breather. Did I even cover burns? I can't remember. Yeah, whatever. I'm sure we did. All right, the patient weighs 100 kilograms after securing his airway, placing the patient on a ventilator. What is the appropriate volume of LR to be administered for burn resuscitation? Yeah, we talked about rule of tens. Good. We hopefully don't need a calculator. What are we thinking? We all remember the rule of tens?
C.
Yeah, C, right? So 30 times 10, and then we're going to add 100 for every 10 kilograms over 80. So should be 500, right? All right, let's keep going here. Well, we'll talk about abdominal trauma today, which really, this is like it's pretty easy. The take-home point is they should probably go to surgery if you suspect any sort of internal abdominal trauma and bleeding, but straight to the OR for any eviscerations, any peritonitis, any unstable patients with a positive FAST exam, any serious mechanisms, but the CT's negative, so that would be like a seatbelt sign on the patient, and they have a normal CT. We usually admit them for observation just because we worry about that like hollow viscous injury that can be difficult to see on that initial CT scan. So, and then never send unstable patients to the CT scanner. And if there's a bladder injury, we want to do that retrocranial urethrogram. I'm trying to think. You can probably just study this slide and be fine for this lecture. If you're like me, when I went through IFAB, I didn't trust anybody. Like, nope. All right. So there's our approach to the critical patient, just like we talked about for a primary survey. So we want to do our X, A, B, C, D, E, F, G, H, I, J. Well, I don't think it goes that far, but we keep adding to it every time. So I'm sure I'll think of something next semester to add to there, another letter maybe. All right, so here's our warm-up. You got a 22-year-old male, stab wound to the belly, arrives to the ED with abdominal tenderness, diffuse scarring, appears pale with cool extremities. Current vital signs are not good. 85 over 50, heart rate 128, respiratory 28, SpO2 294, GCS 15. What are the priorities for this patient? So this patient needs to go to the OR, for sure. You got, unstable vital signs. He's hypotensive, tachycardic. There's some sort of bleeding going on, and if we don't see it anywhere else, we can assume with stab wound that's going to be the abdomen. They need to open them up, so they need exploratory laparotomy. You guys probably haven't talked about that yet. Surgery, right? Oh, you have? Yeah. So they're going to need that lap. So abdominal trauma, very common, you know, especially with motor vehicle accidents, falls, and then we have penetrating wounds, so stab wounds. You know, a lot of people get in fights at bars, things like that. Somebody gets stabbed or shot. We want to, you know, and it can be tricky because anything, you know, some say anything below the nipple lines, but it's very difficult to determine whether anything penetrated the abdomen when you're talking about penetrating trauma. Like I saw a dude shot in his femur, and I'm like, oh yeah, probably not. You know, belly's benign, everything looks normal, but we still pan scanned him, and the bullet was like in his chest, lodged by the spine, and I was like, that's kind of odd. It's like an AK round too. I wouldn't expect it to bounce around like that, maybe like a 22 or something, but it was interesting. So some of the commonly injured organs, you know, liver takes up such a large area in the belly that it's, you know, one of the more commonly injured or penetrating trauma. And then we worry about other, you know, other organs like the spleen, liver, and blunt trauma. And the concern is, you know, hemorrhage inside that belly. So a lot of those organs are very vascular. And so we worry about bleeding inside the belly, especially if we don't have any other source or you don't see any other trauma in that patient. And then even those who make it, they have pretty, you know, they have significant morbidity and mortality secondary to sepsis. All right. So, especially with motor vehicle accidents, worry about that compressive force. So they have a seatbelt in there. Hopefully they're wearing it appropriately, but I mean, I just assume they're not, and we're going to have some sort of other injury with it. Well, blunt trauma is a pretty significant mechanism, common thing we see. And really, any blunt trauma, and they have any peritonitis, especially if they're unstable, they need to go to the OR for that urgent laparotomy. But they're the more common ones we see on there, like falls. Somebody lands on something. It could, you know, can just be an altercation as well, and they take some sort of blunt trauma, and they could rupture a hollow fiscus, which is when they get that peritonitis in there. Maybe not so much bleeding, but they're going to be a septic looking patient when they present, and those ones need to go to the OR and have that taken care of. Which makes it easy for us in the ER. We're like, yep, they need to go to the OR immediately. We need to move them out of here. But what can be difficult is those like penetrating wounds. So any stabs, gunshot wounds. We like to assume, you know, we assume that it had some sort of penetration into that abdominal cavity. But there are certain wounds and missile tracts that may just be a tangential wound that doesn't actually penetrate the fascia. But to be on the safe side, we'll talk about some of our workup and our fast exam and what we're looking for with these patients to help kind of clear them. And like it says on there, you never know where that object is going. You don't know if it broke up into pieces once it entered the body. So we tend to be a little bit, we played on the safe side with these patients. So most of these injuries, if we suspect it penetrated the cavity, they need to go to the operating room. And then evisceration injuries, hopefully that makes sense. You know, they have some sort of organ sticking out of their abdomen. They probably need to go to the operating room for that. And then what do they present with? So big things we're looking at, you know, a seatbelt sign. So you have that ecchymosis kind of coming across the abdomen is what we're looking for. You may have, commonly we see it across the neck as well. Because, you know, seatbelt comes across there, and we won't get into those types of injuries. I think they cover it in surgery, or we used to. Looking at like any of those large vessels there that can be injured with that seatbelt. So that's another significant finding on there. And then we have to consider, you know, a lot of times, especially with like stab wounds, penetrating wounds, there's usually some sort of alcohol or intoxication involved. We also want to consider anybody on anticoagulation because they could have that increased bleeding risk. And then we need to think about young patients and abdominal injuries so they can compensate really well until the end. So you may not see overt signs of hemorrhage in those patients. They might not be hypotensive until later on, especially younger ones like kids. That can be, you know, they can compensate really well until they just fall off that cliff. So we need to consider that with our any of these patients we're evaluating. So contusions, that's going to be the seatbelt sign. You know, we worry about all of that sudden muscular contraction. We get rectus sheath hematomas in there, which can mimic abdominal bleeding. Usually it's not in the abdomen. I think we got a good CT of what that looks like here in a minute. But as the hematoma develops, they start to get more and more pain, and then it could start, that mass can start to occlude abdominal contents and create issues for those patients. And there's how large you can kind of see it is with one of those rectus sheath hematomas in there. All right. So we all remember, Colin's and Gray Turner's sign. Those are other signs of like some sort of retroperitoneal injury, which can be very difficult to assess in the emergency department or anywhere for these patients. So sometimes, like our FAST exam is not going to look at any retroperitoneal injuries or bleeding. So we need to have a higher suspicion for this if we see any of these findings. Then we have all of our solid organ injuries. So they can hide those injuries pretty well, and the patients will compensate appropriately for a while, but sometimes initially the first thing we might see is increased pulse pressure. They might have minimal pain and bleeding, and their body's compensating appropriately, and it can lead to like delayed rupture, especially in our spleen and hepatic injuries. Good news is CT does a great job of identifying those injuries for us and help kind of stage what grade of laceration that is and whether we need to repair it or not. And then here's our classification of hemorrhage that we already covered. Big things, you start to see that increased pulse rate first, so they'll start to become tachycardic. They'll have that decreased pulse pressure, assuming you're taking a pulse pressure. So, they can compensate pretty well for class 1 or up to 750 milliliters, and then they start to show objective symptoms or signs on an exam once it starts to progress. Yeah. So depending on where some of those injuries are, like your spleen can have referred pain up into the shoulder. So that's something the patient might complain of on exam. It'll be left shoulder for spleen and then right shoulder for liver injuries. We also want to consider those splenic injuries in mono and pregnancy as well. They have a higher chance for that. And we always talk about mono and the splenic injuries, but I don't know why I was researching this recently, but I was looking at like what patients actually have a splenic rupture after mono, and I want to say it was like almost all of them don't have any actual trauma afterwards when their spleen ruptures, which is interesting because that's what we talk about: avoid contact sports, avoid everything. And then I was reading, I was like, well, most of the splenic ruptures are actually not associated with any sort of trauma in those patients, which can sometimes make it a little bit trickier. All right. So that's the hollow viscous injuries are always something we need to have in the back of our mind when we're evaluating, because we can't really evaluate them well on CT scan, and it can take time for them to become septic. So they may have some injury there, and they have some slow leak of air or GI contents into the bowel or into the abdominal cavity, and then they slowly become septic. That's why we have a lower suspicion, especially with the mechanism of injury and normal CT scannings, to admit these patients for serial observation and repeat, abdominal exam throughout their stay until we can clear them. All right. So that's kind of what I talked about. So, if it's a chemical irritation, it may produce immediate pain, but it also may not, and it takes a little bit of time for that bacteria to contaminate the abdominal cavity, and then they develop signs and symptoms. So it's safe, if we suspect this, to just admit them to the hospital for serial exam for the trauma service. And then pancreatic injuries can be extremely severe and carry a really high mortality and morbidity rate with them. So this is if we have certain signs and symptoms with it, like the classic one, especially like you're taking a board test, some kid took a handlebar to the belly. But we need to consider it in anybody with trauma, especially Motor vehicle accidents, you know, the seatbelt can cross that area and create these injuries. You know, if an unrestrained driver was hit by the steering wheel, we want to consider it. And then, like I said, the bicycle, you know, anybody riding a bicycle, especially for board questions. I don't know that I've ever actually seen one in real life, like somebody presented the handlebar in the belly and they came in complaining. Usually it's a kid and they like flip over the handlebars and they have a bunch of lacerations is usually what we see. And then duodenal injuries are certainly one of the concerning ones we worry about because it's hard to evaluate. There's like a little loop in there called the C loop. And it can be difficult to evaluate without like oral contrast, and it's not something we typically perform with our emergent CT scans. So these patients, just like pancreatic injuries, we need to have a higher suspicion for it. And then we may have to admit them to the hospital for either a repeat CT with oral contrast, or we serial examine them following that injury and monitor them throughout their course of the stay at the hospital. And then anybody with like a fever, leukocytosis, that's concerning that they have some sort of polyviscous injury or sepsis, abscess, so these patients need to end up going to OR. And then diaphragmatic injury is very, not common, but carries a high mortality rate, so it is something we need to think about with these patients. You can have, very mild symptoms initially with it. They may not initially present with any difficulty breathing. Sometimes on our chest x-ray we may see it abnormal, or it looks like maybe it's similar to a pneumothorax. It can be difficult to tell. In these patients, if we suspect it, especially on the chest x-ray, we want to put an NG tube down there because it is radio opaque, and we can get a chest x-ray to see if the abdominal contents are in the chest. So we could have this from penetrating or blunt trauma. Like it says, it's uncommon, but it is something we always want to consider just because of the associated morbidity and mortality rate associated with it. Commonly, it's on that left side. And then, what do we do for these patients? So, nothing is 100% diagnostic for it. CT is a great study, CT with contrast. So that's what we kind of rely on when we do our pan scanning of the, chest, abdomen, and pelvis. And we're looking for any sort of, bleeding, any extravasation of contrast in there that can be diagnostic for some sort of rupture in those organs. But really, the definitive treatment is they go for a laparotomy. So we need to get them to a surgeon. So, in some cases, so like lower speed motor vehicle accidents, we may not have to do a CT scan if we can, if we have a very benign exam, it was a lower speed mechanism, they're not complaining of abdominal pain, we're not having anything on palpation or concerns. There are times we don't have to do everything and draw all our labs, run our CT scans, so that's going to be based on, the patient's presentation. We also want to consider if they're on anticoagulants, we need to have a lower threshold for scanning these patients, but not everybody requires a pan scan to present. All right, and this is going to be like one of our rapid and reliable mainstays is going to be our EFAST exam. So, it's great for that undifferentiated hypotensive patient. And then we get a positive FAST exam, so that can be diagnostic for some sort of bleeding. We don't know where it's coming from, which is the limitation to it. But it will help guide us to say, yeah, we probably need to open up that patient's belly and determine where that bleeding's coming from. Then you go to the OR. And there's our advantages. Fast. We're going to practice it all of our next block, so you guys will be very good at identifying negatives, which is, which is good. So when you see a positive, hopefully you can identify it. But it is fast. We don't have to give any contrast. We can do it at the bedside. They say it takes, I guess if you're doing it extremely completed be 4 minutes. I think in the trauma room it's probably like less than a minute we're doing that fast exam. I mean, usually it's during our primary survey and somebody is going to be the fast person and they're kind of putting that probe on there while they're stabilizing and performing the primary survey and taking care of everything else. But it is a great tool. They're pushing out the ultrasounds to every battalion. I think they started at Fort Bragg and they might have already, allegedly, you know, they've been saying it for like probably the entire time I've been a PA that they're going to have ultrasounds, but allegedly they started rolling them out. So you guys will hopefully have them in your units by the time you get there. What's nice is, you know, it can be, you know, diagnostic, especially if you get that right upper quadrant view. You see some fluid that shouldn't be there that can help you identify it. Somebody with bleeding. If they're stable, we still may get a CT scan, but they should be opened up at that point or sent to the OR for an exploratory laparotomy. We can also look at other things, so we can guide a suprapubic catheter with it. We can look for any free fluid down in the pelvis as well. And then we can check their hydration status or fluid status, volume status, looking at that IVC diameter, which we'll practice that a little bit as well. And like I said, you know, we don't know the amount or the location that bleeding's coming from. So we know something's going on in there. We don't know how much. So if they're stable enough, they may go to the CT scanner. Our preference in the trauma room is they go to the operating room. But once again, you know, if they're stable, we may send them to the scanner. I mean, I think the scanner is where people go to die. All right, what do we see on this?
Normal?
Looks normal? We agree? Yeah.
Any fluid?
Normal, right? So let's kind of run through here, and we'll go through anatomy a lot better once we're in our next block, but let me see if I can find my little laser thingy. So this is the liver. This is your diaphragm here. Oh, and then they're sliding down. They're looking at the kidney. And we want to get that caudal tip of the liver, which is right here, and abnormal will have like a fluid stripe above that kidney and in between that liver, which we should have on the next slide. Oh, that's not, there we go. Let's see what we got here. Oh, it's pretty fast. That's why I say that we do it a lot faster in 4 minutes. Maybe 4 minutes we could look at this image a little bit better. But all right, so you guys see there's a little stripe on there, like you see that fluid kind of hiding right there. That's going to be a positive fast exam in that right upper quadrant, or Morrison's pouch. Let me see if we have some other ones here. No, all right. So gold standard is going to be our CT with contrast to the abdomen and pelvis. You know, we can identify what grade of injury, especially with like commonly our liver lacerations, our splenic lacerations. Our goal is to manage them non-operatively, so unless it's a higher grade laceration, most of them are going to be managed without surgery in those lower grades. But it's great for surgical planning when we can get that CT scan and kind of decide what we want to do with it. It also is better at evaluating those retroperitoneal injuries, which we can't really see with the ultrasound or the fast exam. And then there's our disadvantages of CT scanning. So exposes them to radiation. I mean, it doesn't expose me to radiation, so I'm not too worried about it. But we also need to worry about, you know, they're getting contrast as well, so we need to think about kidney function. The biggest issue in a trauma patient is they have to leave the trauma room and go sit in the scanner for, you know, however many minutes until it's complete. And we worry about them decompensating in there and end up coding in the scanner, which happens more frequently than I would prefer. And then when they come out, they blame us, and we blame them, and it's, just back and forth because nobody wants to take the hit that it was their fault. Which is why we prefer them to go to the OR, and the surgeons prefer to get the CT scan. So it's just one of those things we have to deal with. And then here's a nice CT scan of a splenic laceration, so you can kind of see that hypodense area or that bleeding in there. So that's indicative of laceration. And then they'll give a grading on it, which I don't know if you guys talk about in surgery or not, liver and splenic grades, but usually the radiologist will give you an interpretation of what grade they think that is. All right, so penetrating trauma. This is where it can get, this is where it can become difficult. So if they have an anterior chest wound or abdominal wound or anything really below the nipple line or below is what we tend to say we need to consider some sort of like intraperitoneal injury. We can locally explore them if the patient is stable and we don't think they violated that fascia. But most of them we would prefer to take to the operating room and explore it more thoroughly. But we can incise that wound a little bit more and actually down to the fascia and visually see whether it violated that. So those will be like the more tangential if it's GSW or a stab wound. But most of them we consider to be in the intra-abdominal cavity, especially with gunshot wounds. All right, and there's our gold standard for treatment. So that's going to be the exploratory laparotomy. So they're going to make a big incision, basically from the entire anterior portion of the abdominal cavity. They're going to open it up, and they're going to look around there for any sort of injury to those structures of where that bleeding is coming from. And it's kind of cool. You guys will, hopefully watch some or take part in some during your phase 2 rotations. And it's kind of cool how it's amazing how fast they can do it. And they open up and they're just like pulling all of the bowel, and they're just running the entire bowel looking for where they can find that bleed. So it's kind of cool how if you guys are able to assist in those or watch them. Some facilities like University Hospital in San Antonio, the other trauma center, they actually have a live feed to their surgeries from the trauma room because they have a huge surgical residency there, so they all sit there and watch it in between trauma patients. They're super nerded out, all of them watching. I'm like, it's kind of cool. But they get really into it, watching and judging the surgeon that's doing it. So I'm like, that's kind of funny. I would hate to be that surgeon and they're being judged by 25 people watching it on video feed. But anybody that's hypotensive that we suspect abdominal wall disruption or peritonitis, they need to get surgically explored. And then non-operative management. So, we see a lot of blunt trauma, and, honestly, non-operative management is probably the most common thing we do in these patients. Not everybody goes to the operating room. I think if you look at the figures, it's I want to say less than 40% at the largest trauma centers actually go to the operating room. So most patients are actually going to be managed non-operatively when you actually sit down and run the numbers and think about it. So CT is going to be our mainstay for that. And especially if they're stable, they're likely not going to go to the operating room. So if we suspect any sort of injury or CT scan shows we have any of those like splenic lacerations, liver lacerations, we'll oftentimes admit them and serial evaluate them. And then work on the disposition for those patients, which you guys will talk about in surgery, because in the ER we don't we like to dispo them inpatient, and then whatever happens after that, we don't worry about it. We're not going to talk about REBOA, but it is still in the your CPGs for trauma, your TC3 protocols, but it's not something we're performing very often. I think the latest one, I think most of the people that have performed them are usually on a patient that's expiring, unfortunately. There's how it looks. We go through the femoral artery and we insert that catheter and we place a balloon there. And it's similar to that resuscitative thoracotomy where we cross-clamp the aorta. We want to keep the blood to flow into those vital organs like the heart and brain. So any stable patient, we have a choice for managing them non-operatively. So like I said, we admit them to the hospital, serial examinations until we can determine that it's not going to progress, especially for those like hepatic and splenic lacerations that we see. We can consider reversing any of those anticoagulants. However, the data is not great at supporting it or showing much benefit for reversing those agents acutely. But it is a consideration that you might see. So depending on what they're taking, whether it's warfarin versus a DOAC, we have reversal agents that we can use for that. And then what's the disposition? So most of them are going to be admitted. If we have any sort of findings on our CT scan and they're stable, anybody unstable, they're going to be treated in the operating room with an exploratory laparotomy. And then some patients will be discharged from the ED. And those are going to be like your normal CT scans. They don't have any signs of, they don't have any seatbelt sign or any ecchymosis on the belly. They're stable, and they have good follow-up in case they need to return to the ED. They need to have a primary care manager that they can follow up with shortly after as well. And then anybody that shows signs of like peritonitis, so fever, vomiting, worsening pain, or any symptoms of blood loss, we need to make sure those patients return promptly for reevaluation. And then there's a nice motor vehicle accident. I know that was fast, but like I said, that first slide kind of sums it up. Any signs of any unstable signs, and we think it's the belly, they need to get an X-slap. And then anybody else with CT findings, but they're stable, we need to look at either admitting them for serial observation or taking them to the OR. And then other patients can be discharged if we don't have any significant findings. What questions y'all got? No, that was fast. All right. I believe that was the last trauma lecture we have. So next week we have our trauma lab, which will be fun for most of you. Some of you who've done it before may not be as fun, but this is like the crawl, walk, run phase. So we're going to have airway stations, so you get to practice all the different interventions we have for the airway. We have a breathing station, we have chest tube trainers, and then we have trauma scenarios where we'll put you guys in charge and kind of run through trauma. So it'll be fun. Don't worry, we'll guide you through it. It'll be a good time. Most people enjoy it. So if you guys would like a review for it, I'm happy to do it next week. I don't think we're going to need that 1500 block on Monday. You guys